Hello, my name is Jerry Shapiro. I'm from NYU, and we're going to talk about new and emerging therapies in the treatment of alopecia areata. I would like to thank Dr. Kristen Losico, as well as Elizabeth Klein and Maria Karim in the preparation of this presentation. These are my disclosures. These are companies that I'm a consultant or investigator for. Now, many therapies are available for the treatment of alopecia areata. For most patients, it's appropriate to begin by following a simple treatment algorithm that we published a while ago that is also on the National Alopecia Areata Foundation website. First, trialing therapies with abundant evidence of efficacy and safety profiles. What I'd like to do is talk about other treatments. Alopecia areata is unpredictable, and there may be a subset of patients for which no traditional treatment is effective. Improved understanding of the pathomechanisms of alopecia areata has guided the development of increasingly targeted therapies. We'll talk about dupilumab, ustekinumab, abatacept, apremilast, and BNZ. We'll also talk about procedures such as platelet-rich plasma, microneedling, fecal transplantation, and mesenchymal stem cell therapy. So we'll talk about medications and then procedures. First of all, dupilumab. Monoclonal antibody, which inhibits interleukin-4 and IL-13 receptor to disrupt Th2 response. That's the mechanism of action. By disrupting IL-4, it prevents Th0 conversion to Th2 cells. Disruption of Th2 inhibits further promotion of interleukin-4 and interleukin-13, key drivers of type 2 inflammation. This is used in the treatment of moderate to severe atopic dermatitis, moderate to severe asthma, as well as chronic rhinosinusitis with nasal polyposis. Now, in terms of in alopecia areata, it's potentially useful due to the findings of Th2 activity and genetic polymorphisms of interleukin-4 and interleukin-13 in AA scalp biopsies. And you can see from this particular article here that when we look at certain expressions of IL-13, for instance, in non-involved skin and involved skin, there is an elevation of IL-13, more so in involved skin than non-involved skin. So there is this whole potential of IL-13. And then IL-4 and IL-13 increased production and signaling are key drivers of type 2 inflammation. So Emma Gutman recently published a randomized double-blinded placebo-controlled study, 60 patients with moderate to severe alopecia areata, treatment with dupilumab for 48 weeks. And what she showed was that 32.5%, 22.5%, and 15% of patients achieved SALT 30, SALT 50, and even SALT 75 improvement, respectively. In patients with baseline IgE levels of more than 200 international units per milliliter, response rates to dupilumab treatment further increased to 53.8%, 46.2%, and 38.5%, respectively. So there may be a role for measuring baseline IgE levels in patients with AA as a predictive factor for the treatment with dupilumab. Paradoxically associated with the development of alopecia areata in patients treated or for atopic dermatitis, there are some people who developed alopecia areata. So there are people who have gotten alopecia areata while on dupilumab, so we have to take that into account. However, Dr. Gutman's results are quite impressive. Now, there are side effects with it, which include injection site reaction, conjunctivitis, blepharitis, keratitis, eye pruritus, dry eyes, oral herpes, and HSV infection. Let's talk about another drug, ustekinumab. It's a monoclonal antibody which inhibits the activity of IL-12, IL-23 cytokines by binding to the P40 subunit. It disrupts IL-12 and IL-23 mediated signaling by inhibiting interaction of these cytokines with a shared receptor chain, IL-12RB1. In doing so, it decreases activation of natural killer cells and differentiation of naive T cells into CD4 T cells. It's used already in the treatment of moderate to severe plaque psoriasis, psoriatic arthritis, moderate to severe Crohn's disease, and moderate to severe ulcerative colitis. And again, when we look at IL-23P19 and we look at in uninvolved skin and involved skin of alopecia areata, and we compare it to normal scalp, we see that there is definitely an increase in the amount of not only IL-23P19, but IL-12, IL-23P40. So just to give you an idea that this may be the mechanism of action, it's potentially useful in alopecia areata due to findings of IL-12 and IL-23P4 activity in alopecia areata scalp biopsies, involved skin and non-involved skin. Now, Dr. Gutman also has used this and shown some evidence of efficacy with 3 patients with moderate to severe alopecia areata treated with ustekinumab 90 milligrams every 4 weeks for 16 weeks. All patients showed some regrowth at 20 weeks. 1 patient showed full regrowth of scalp hair at 49 weeks. And you can see the pictures here on the right. Alisa et al. Had a case series of 3 pediatric patients with alopecia areata treated with one-time injection of ustekinumab 90 milligrams or ustekinumab 90 milligrams at 0, 3, 6 months. And all patients showed some regrowth at 4 months. So this is another option possibly for patients in the future. Again, paradoxically, it may be associated with psoriasiform alopecia in a pediatric patient, which was shown. Additionally, it can be associated with injection site reactions, headache, and fatigue. What about abatacept? Well, the mechanism of action is the CTLA-4 immunoglobulin co-stimulatory modulator. It competes with CD28 for CD8/B7 to inhibit T cell co-stimulation by antigen-presenting cells. It reduces T cell proliferation and activation, which in turn reduces B cell activation and formation of autoantibodies. It's already being used in moderate to severe rheumatoid arthritis, moderate to severe polyarticular juvenile idiopathic arthritis, and psoriatic arthritis. Potentially, it is useful in AA, as suggested by a study in mouse models by Carroll et al., showing that there was some change of 15 mouse models receiving an AA graft and administered this MCTLA-4-M-IgG2AM. 14 did not develop alopecia areata. Histologically, examination of hair follicles, these mice showed absence of typical lymphocytic infiltrate. So it helped to prevent further alopecia areata in these animal models. Mackay-Wigan at Columbia also showed in a single-arm clinical trial 14 patients with moderate to severe patchy type alopecia areata treated with abatacept 125 milligrams per day for 24 weeks. 10 out of 14 study patients exhibit regrowth of scalp hair or eyebrow hair with scalp biopsies demonstrating normalization of alopecia areata inflammatory genes. 1 patient exhibited complete scalp regrowth. 4 patients exhibited 15 to 25% scalp regrowth. 4 patients 3 to 10% scalp regrowth. 1 patient exhibited eyebrow regrowth, and 1 patient exhibited actually worsening of the alopecia areata. Paradoxically, again, there are people who've gotten psoriasiform alopecia in a pediatric patient on abatacept. Other side effects with it are headache, dizziness, nasopharyngitis, cough, back pain, and hypertension. What about apremilast? Does that help? Well, the mechanism of action, it's a small molecule inhibitor of phosphodiesterase. By inhibiting PDE-4, it causes decreased levels of cyclic AMP, an intracellular secondary messenger to decrease the release of other pro-inflammatory cytokines. So it prevents a cascade of events. It's already used in psoriatic arthritis, moderate to severe plaque psoriasis, and ulcers with Behçet's disease. It's potentially useful in AA as suggested by a study in mouse models. In 6 mouse models receiving AA grafts and administered apremilast, 11 out of the 13 grafts did not develop alopecia areata. Histologic examination of hair follicles showed significantly decreased levels of interferon gamma as well as TNF alpha. So it looks like it may have a place in alopecia areata. We've used it in some patients and it didn't seem to work, but perhaps we need to use it on a larger number of patients. The evidence, this was a case series by Estabanez et al. 4 patients with severe alopecia areata treated with 30 milligrams BID times 5-day titration. Patient 1 exhibited significant hair growth at 12 weeks. Patient 2 exhibited improvement after 12 weeks of treatment. Patient 3 exhibited complete hair regrowth after 8 weeks, and patient 4 exhibited improvement after 6 weeks. So it looks like there may be some benefit in using this. However, there's conflicting evidence. Here we have a study with 30 patients randomized 2-to-1 to receive oral apremilast for 24 weeks. And by 24 weeks, only 1 of 12 achieved a primary endpoint of a SALT score reduction of 50%. No statistically significant difference between mean improvement of SALT score by week 24 of the 2 study arms. 8 patients in the apremilast arm withdrew prior to week 24, mostly due to lack of efficacy and adverse events. Another study by Liu et al. 9 patients with severe alopecia universalis treated with apremilast 30 milligrams BID for 3 to 6 months. None of the patients experienced scalp hair regrowth over 3 to 6 months. This mirrors our cases that we used it on. We didn't get regrowth. What are the side effects? Diarrhea, nausea, headaches, and lethargy. What about platelet-rich plasma? Autologous blood products are centrifuged to extract plasma rich in growth factors and cytokines, including platelet-derived growth factor, fibroblast growth factor, epithelial growth factor, insulin-like growth factor, TGF, and VEGF. Growth factors may stimulate folliculogenesis, angiogenesis, and epidermal proliferation. As a result, you may prolong anagen phase of the hair cycle. Data supports the theory that PRP may decrease levels of interferon gamma and IL-17. In randomized placebo-controlled split-head study, mean interferon gamma and IL-17 MRI expression decreased in alopecic lesions in this particular study by Gupta et al. So this gives you an idea that maybe PRP, we do use it. If my intralesional does not help, I will use PRP as well. We use it a lot in androgenetic alopecia, and it may help some people with alopecia areata. Here's another example by Trink et al. Randomized double-blind placebo-controlled study. 45 patients randomized to receive PRP, triamcinolone, or placebo to have the scalp. PRP increased hair regrowth significantly compared with triamcinolone and placebo, and 60% of patients treated with PRP had remission at 12 months compared to 27% treated with triamcinolone. Hedge et al. In a randomized double-blind placebo-controlled study, half-head study, 50 patients randomized to receive PRP or triamcinolone acetonide or placebo on one half of the scalp. The PRP showed significant improvement in SALT scores from baseline. So there may be something to PRP. However, there is conflicting evidence. This study, 27 patients with AA randomized to monthly PRP for 3 months or normal saline. The mean SALT score did not change significantly from baseline PRP or placebo group. However, mean percentage change in SALT score in the PRP arm was greater than in the placebo arm. mean IL-17 and interferon gamma mRNA expression in the PRP arm did decrease. So there may be something to it. However, it's something I try when nothing else seems to work. The adverse effects, hardly anything except pain and bleeding. What about microneedling? Well, physical puncture of the skin may have an effect on transcutaneous drug delivery, and so it allows the drug to penetrate more easily. So if you're giving a topical medication, it may increase the efficacy. Monotherapy may upregulate Wnt3A, beta-catenin, VEGF, WANT10B protein expression to mediate growth of hair shaft. It's already used in the treatment of acne and acne scarring. Microneedling, a review, an article of 4 studies of alopecia areata patients who received microneedling as delivery modality for topical medications. 2 studies demonstrated positive improvement in hair growth when using microneedling and triamcinolone. 2 studies demonstrated increased hair growth combining microneedling with photodynamic therapy using methyl 5-aminolevulinic acid. Actually, over 20 years ago, we did a study with ALA on patients who had universalis, and it really didn't work. But we didn't do microneedling. Maybe if we had done microneedling 20 years ago, we might have had better results. The microneedling adverse effects: erythema, pain, tram track scarring, and infection risk. What about fecal microbiota transplantation? Using FMT is basically taking fecal microbiota from one patient and giving it to an AA patient and changing the microflora. This has been used in C. difficile infection as well as inflammatory bowel disease. And there are cases already of people using it in patients who had also alopecia areata, and they were able to regrow some hair in certain patients, particularly 2 patients with alopecia universalis treated with this fecal microbiota transplantation for C. difficile. So I think this is something that may be used in the future. I know clinical trials will be starting in the future at Columbia University. The problem with this are adverse events: vomiting, fever, bacteremia, diarrhea, peritonitis, and diverticulitis. Now, what about mesenchymal stem cell therapy? Stem cells are known to inhibit proliferation of T cells and B cells and alter cytokine secretion. They're found to decrease interferon gamma-induced cytokine and chemokine release. They've been studied in vitro models of alopecia areata using pretreated human dermal papilla cells, found to inhibit JAK-STAT pathway and activate Wnt beta-catenin pathway to induce hair follicle reentry into anagen. Used in the treatment of graft versus host disease, atopic dermatitis, and rheumatoid arthritis. So there may be something behind mesenchymal stem cell therapy. Here we have a study on 20 AA patients treated with these stem cells from stromal vascular fraction. 9 out of 20 showed a significant increase in hair shaft diameter. 18 out of 20 demonstrated a significant increase in hair density. Another study on 14 patients with refractory alopecia areata treated with combination of adipocyte-derived stem cell conditioned media and fractional laser or microneedling. 9 demonstrated over 50% hair regrowth, and 6 demonstrated complete recovery as assessed by photographs and SALT scoring. Here's another study, again, 3 alopecia areata patients treated with minimally manipulated human umbilical cord derived mesenchymal stem cells. Case 1 showed patchy AA, which resolved completely with no recurrence. Another case with patchy AA resolved completely with no recurrence. And then here's alopecia universalis, which showed new hair regrowth in this particular in case 3. So there may be something behind this. here again is, again, other cases where it has been used, and you can see that there has been regrowth in these cases by An et al. It shows that there may be some usefulness of using these kinds of adipose type stem cells. The problem is inflammatory reaction at the injection site, which can occur. Now, what about BNZ-1? That's from a company called Bionese-1. Now, I'm not aware that they're continuing to do more studies with this, but it has great potential. It is a multi-cytokine inhibitor of IL-2, IL-9, and IL-15. IL-2 and IL-15 are involved in propagating the pathogenic response of interferon gamma producing CD8 plus T cells and natural killer cells. Have also been associated with supporting autoreactive CD8 plus T cells. So it has something to do with reducing the inflammatory response. There is currently a phase 2 randomized double-blind placebo-controlled multi-center trial underway investigating the utility and safety of 0.5 milligrams per kilogram weekly and 2 milligrams per kilogram Q weekly with BNZ-1 patients with moderate to severe alopecia areata. So there are actually some studies going on, but I'm not sure of how far they're into these studies. The problem is pruritus, fatigue, and dry skin. So here we have a summary of dupilumab, of ustekinumab, abatacept, apremilast, PRP, microneedling, fecal transplant, stem cell therapy, and BNZ or Bionese-1. And you can see that, that things are progressing. Okay, and we're hoping to see more results with stem cell therapy and BNZ-1. We're hopefully we'll see more with fecal transplant from Columbia University. So these are the new emerging therapies. These are the references, and I thank you so much for allowing me to give you this particular talk. Thank you.